We have finally made it to Unit 4, to the final unit of MLT 111. And in this unit, we're going to be covering kind of miscellaneous information. So we're going to go through the renal diseases, metabolic disorders. We're going to cover other types of body fluids besides urine. So we'll talk about spinal fluid, synovial fluid, the serous fluids, amniotic fluid, and fecal examination. So this very first lecture video we're going to cover renal diseases and metabolic disorders, which is a lot of information, so this probably will be a slightly longer video. Okay, so to start out, we're talking about renal diseases. One of the main functions of the kidneys is to remove waste products from the body, so they're constantly coming in contact with substances that could potentially cause damage to the kidneys. The renal diseases are categorized based on the area of the kidney that's affected, so they're broken down into glomerular disorders, tubular disorders, interstitial disorders, renal failure, and renal lithiasis or calculi. So that's how we will go through these different disorders, is based on those categorizations. So in the glomerular disorders, most of these are going to be the result of immunologic disorders that cause release of serum immunoglobulins, which deposit themselves on the glomerulus. Other elements involved in the immune response, such as complement, white cells, and cytokines, can also congregate to the area, and this eventually causes changes and damage to the membrane. Other non-immunologic causes could be exposure to chemicals or toxins, the acute phase reactants, which are proteins that increase in response to inflammation, amyloid material, which is an abnormal proteins that group together and deposit on the tissues, and basement membrane thickening and disruption of the electrical membrane charge. Okay, so the first one we're going to talk about is glomerulonephritis. It's a general term that refers to a sterile inflammatory process that affects the glomerulus. It's associated with the presence of blood, protein, and casts in the urine. Many types exist, and one can lead to another, usually progressing through the course of various renal disorders. In acute peptostreptococcal glomerulonephritis, this one is not very common anymore, and that's just because of the rapid tests that we have available to detect a group A strep infections. Acute means that there's going to be a sudden onset of symptoms. This is usually seen in young adults and children after an infection with strep throat. The antibodies associated with group A deposit in the glomerulus and will affect glomerular function. In the urine, you would expect to find hematuria, protein, red cell casts, dysmorphic red cells, hyaline and granular cast, and there will also be a decreased output of urine. Urinalysis results will return to normal as those toxic substances disappear. In rapidly progressive or crescentic glomerulonephritis, this is still considered an acute disease, but it's much more serious and is very rapidly progressive, so there's a much poorer prognosis, and it can lead to renal failure. Once again, immune complexes deposit themselves in the glomerulus. This usually happens as a result of another form of glomerulonephritis or an immune system disorder, such as lupus. Macrophages cause damage to the capillary walls, which leads to permanent damage to the capillary tufts caused by fibrin. In the beginning, this disease can present like other acute forms, but then results are going to become more abnormal as the disease progresses. Some common lab results that you would expect to see in this disease: markedly elevated protein levels, very low glomerular filtration rate. Some forms of the disease can also exhibit increased fibrin degradation products, cryoglobulins, and deposits of IgA in the glomerulus. Next is Goodpasture's syndrome, which is an autoimmune disorder in which an antibody forms against the glomerular and alveolar basement membranes. This is called the anti-glomerular basement membrane antibody. This usually occurs after a viral respiratory infection. It causes complement activation, which leads to capillary destruction. And the initial presentation consists of coughing up blood. It can lead to shortness of breath. Hematuria will then develop along with proteinuria and red cell casts. This disease can lead to chronic glomerulonephritis and renal failure. Next is Wegener's granulomatosis, which is an inflammation of the small blood vessels, usually of the kidney and respiratory systems, that produce granulomas. Granulomas are a small nodule of an accumulation of cells. It causes the production of anti-neutrophilic cytoplasmic antibody, or ANCA, that binds to neutrophils and initiates the immune response. So it presents initially with pulmonary or lung-related symptoms. The patient will later develop renal involvement, including hematuria, proteinuria, red cell casts, and elevated serum creatinine and BUN. Okay, next is Henoch-Schönlein purpura, which occurs primarily in children following an upper respiratory infection. It will start with raised red patches on the skin, blood in the stool, and sputum can also be seen. Renal complications are the most serious side effect, presenting as proteinuria, hematuria, and red cell casts. In about half of the cases, the disease progresses to a more serious form of glomerulonephritis that could lead to renal failure. Next is membranous glomerulonephritis, where you've got IgG immune complexes that deposit in the glomerular basement membrane that causes thickening of the membrane. This disorder is associated with lupus, Sjogren's syndrome, which is a condition that causes the mouth and eyes to become very dry. It's also associated with secondary syphilis, hepatitis B. The progression of this one is slow and remission is possible. There's also a tendency toward thrombosis with this one. Thrombosis is a clot that forms when blood flow is impeded in some way. Lab findings with this one include microscopic hematuria and increased protein excretion, where it will be very high. Next is membranoproliferative glomerulonephritis. So with this one, we've got two types. Type 1, where you'll see increased thickening of the capillary walls in the glomerulus and peripheral capillaries. This one advances to nephrotic syndrome. And then type 2, where you've got dense deposits in the glomerular basement membrane, which progresses to chronic glomerulonephritis. These are going to be mostly seen in children, and it's associated with autoimmune disorders, infections, and malignancies. And lab findings with this one would be hematuria, proteinuria, decreased serum complement levels. Next is chronic glomerulonephritis. So all of the previously discussed disorders can progress to chronic glomerulonephritis depending on the duration and the severity of the damage caused. Worsening symptoms can include fatigue, anemia, hypertension, edema, and oliguria. Lab findings associated with chronic glomerulonephritis include hematuria, proteinuria, glucosuria, a variety of casts, a decreased glomerular filtration rate, increased BUN and creatinine, and electrolyte imbalance. Okay, next is IgA nephropathy, which is also known as Berger's disease. This is the most common cause of glomerulonephritis. IgA deposits in the glomerular membrane, which could be due to a mucosal infection. It's usually seen in children and young adults. Your lab results associated with this one, you'll have macroscopic hematuria following an infection or strenuous exercise from which the patient recovers spontaneously, but microhematuria and increased serum IgA levels remain. With this one, the patient can be asymptomatic for as long as 20 years, except for sporadic episodes of macroscopic hematuria. And even though it shows no symptoms at varying times, it can still gradually progress to chronic glomerulonephritis and end-stage renal disease. Okay, nephrotic syndrome can occur as a complication of various forms of glomerulonephritis, or acute onset occurs in instances of systemic shock due to circulatory disruption. This results in decreased pressure and flow of blood to the kidney. You'll have high molecular weight proteins, lipids, and albumin that are allowed to pass into the urine. Depletion of immunoglobulins and coag factors puts the patient at an increased risk of infection and coagulation disorders. Tubular and glomerular damage occurs, and this one can progress to chronic renal failure. Your lab findings for this one, severe proteinuria. This will be the highest level of proteinuria of all the disorders. Also urinary fat droplets, oval fat bodies, RTEs. You can see epithelial fatty and waxy casts, microscopic hematuria, decreased serum albumin, increased serum lipids, and extreme edema. Minimal change disease. This one's also known as lipid nephrosis. It produces little damage to the glomerulus, but it still allows increased protein filtration. This one's usually seen in children presenting with edema, proteinuria, transient hematuria, but they'll have a normal BUN and creatinine. They don't know what causes it exactly, but it has been associated with allergic reactions, recent immunization, possession of HLA antigen B12. The prognosis for this one is good as it responds well to corticosteroids. Then the last one in this category is focal segmental glomerulosclerosis, which affects only specific areas of the glomerulus. The symptoms with this one are going to be similar to minimal change disorder and nephrotic syndrome. This one is associated with heroin abuse and abuse of analgesics, which are pain relievers, also associated with HIV. Lab findings for this one, proteinuria and microscopic hematuria. Okay, moving into the tubular disorders. These are disorders that affect the renal tubules, either by actual damage to the tubules or by a metabolic or hereditary disorder. The first one is acute tubular necrosis. So this is a major disorder associated with damage to the renal tubules, both the distal and the proximal, which is caused either by ischemia, which is decreased blood flow causing lack of oxygen in the tubules, or by the presence of a toxic substance in the urinary filtrate. The prognosis for this one is good if the ischemia is corrected or if the toxic substances are removed. Lab findings that you would expect with this one include mild proteinuria, microscopic hematuria, RTE cells, and RTE casts. A variety of other casts may be present also due to the tubular damage. Okay, some hereditary and metabolic tubular disorders. So these are going to be disorders that affect tubular function that are caused either by systemic conditions that affect or override the tubular reabsorptive maximum for certain substances, or by failure to inherit a gene or genes required for tubular reabsorption. The first one is Fanconi syndrome, which is a disorder that is most often associated with tubular dysfunction. It's a generalized defect in the reabsorption abilities of the renal tubules that is either inherited in association with other disorders or can be acquired through exposure to toxic agents. It can also be a complication of multiple myeloma and renal transplant. Your lab findings with this one would be glycosuria with a normal blood glucose, possible mild proteinuria, can have very low urinary pH due to the inability to reabsorb bicarbonate. Next is Alport's syndrome, which is a genetic sex-linked disorder that affects males more severely than females. You've got, in this one, patients have a glomerular basement membrane that is lamellated, which means it occurs in sheets and has areas of thinning, but there are no glomerular antibodies. The prognosis for this one can range from mild symptoms to persistent hematuria and renal insufficiency in later life. to nephrotic syndrome and end-stage renal disease. With uromodulin associated kidney disorder, uromodulin, remember, which is also TAM horsefall protein, it's the only protein produced by the kidneys in the distal convoluted tubules and the proximal convoluted tubule, and it is the primary protein found in normal urine. This is an inherited disorder caused by an autosomal mutation in the gene that produces uromodulin, so that the normal form of TAM horsefall is replaced by the abnormal form, and it accumulates in the cells, causing destruction. Renal monitoring is necessary, and eventually transplant would be necessary. Other significant findings in these patients is an increased production of uric acid in the serum, which can cause early onset of gout. Next is diabetic nephropathy. This is the most common cause of end-stage renal disease. You've got glomerular damage, including thickening of the basement membrane and deposits of materials within the glomerulus. This one is thought to be caused by a deposition of glycosylated proteins resulting from poorly controlled blood glucose levels. Microalbumin testing is important for monitoring. This one, because it's an indication of the extent of the glomerular damage, and modification of diet and hypertension can all help to decrease the progression of the renal disease. Next is nephrogenic diabetes insipidus, in which the action of ADH, or antidiuretic hormone, is disrupted. So this happens in one of two ways. So there's two forms of the disease. The first one is nephrogenic, which is sex-linked inherited gene that causes the tubules to not respond properly to ADH, or it can also be caused by exposure to certain medications, or can also be seen as a complication of polycystic kidney disease and sickle cell anemia. The second type is called neurogenic, in which the hypothalamus just does not produce ADH. Urinalysis results would have a low specific gravity, and the urine would be pale yellow. In renal glycosuria, this is an inherited disorder that affects the body's ability to reabsorb glucose from the glomerular filtrate. So patients with this disorder will have increased urine glucose with normal blood glucose levels. This is caused either by a decreased number of glucose transporters in the tubules or a decreased affinity of the transporters for glucose. Moving now into the interstitial disorders. These are going to be disorders that affect the interstitium and also the tubules. The most common renal disease is UTI, which can be in the upper or lower urinary tract. Most commonly seen is a bladder infection known as cystitis, which can progress to an infection of the upper urinary tract if it's not treated. These are seen more often in women than men, and symptoms include urinary frequency and burning. The urinalysis will show many white cells and bacteria, sometimes with proteinuria, hematuria, and increased pH. Okay, acute pyelonephritis is an infection of the upper urinary tract to include the tubules and the interstitium. It's related to interference of the urine flow, which could be due to an obstruction or some other type of condition. It's most commonly caused by ascending movement of bacteria from a lower UTI into the renal tubules and interstitium, or from reflux of urine from the bladder back into the ureters. There's a rapid onset of symptoms that can include urinary frequency, burning, and lower back pain. All can be resolved with antibiotics. Your urinalysis results would be similar to those seen in cystitis, so you can see many white cells, bacteria, mild proteinuria, hematuria, but the presence also of white cell casts signifies an infection within the tubules, and so white cell casts are diagnostic for acute and chronic pyelonephritis. You might also see bacterial casts. And then chronic pyelonephritis is a congenital urinary structural defect that produces reflux between the bladder and ureters. So that's the most common cause. It's often diagnosed in children and can result in permanent damage to the renal tubules and possibly progress to chronic renal failure if it's not caught early enough. To treat, you have to correct the structural abnormality. Urinalysis results are the same as acute pyelonephritis in the early stages, but as it progresses, there will be a variety of granular, waxy, and broad casts seen. Also increased proteinuria, hematuria, and decreased renal concentration. So you would see a decreased specific gravity. Acute interstitial nephritis is an inflammation of the renal interstitium followed by inflammation of the renal tubules. It's primarily associated with an allergic reaction to medications. Most of the time, the condition can be reversed if the medication is discontinued and steroids are administered to control the inflammation. Your urinalysis results, you'll see hematuria, mild to moderate proteinuria, lots of white cells, white cell casts, but no bacteria. Increased eosinophils can be used for diagnosis, and remember you use the Hansel stain for that. Okay, finally, renal failure exists in acute and chronic forms. Usually the chronic form is the result of progression from the acute form, and then it can progress further to end-stage renal disease. It's characterized by a distinct decrease in the GFR, which would be indicated by a result less than 25 milliliters per minute, steadily increasing serum BUN and creatinine values, electrolyte imbalances, proteinuria, lack of renal concentrating ability, which would produce an isothenuric urine, renal glycosuria, and many granular, waxy, and broadcasts would be present. The acute form will come on suddenly, but most times is reversible. And you can have pre-renal, renal, and post-renal causes. And even though patients can present with a variety of symptoms depending on the cause, decreased GFR, oliguria, edema, and azotemia are normally also present. Your urinalysis results for this one are going to be related to the cause and can be a diagnostic tool in determining where the problem is originating. And the next slide here is just a list of different causes of acute renal failure broken down into your pre-renal, your renal, and your post-renal causes. Okay, the final renal disease is, that we're going to talk about is renal lithiasis, also known as renal calculi or kidney stones that form in the calyces and pelvis of the kidneys and in the ureters and bladder. They can come in a variety of sizes and shapes. Small ones can be passed in the urine. Larger ones may have to be removed through lithotripsy or surgery. The patient may present with severe lower back pain that can radiate to the abdomen and into the legs. And just like with crystals, pH and chemical concentration and urinary stasis can all play a role in the formation of stones. Analysis of the chemical composition of the stone helps to play a role in the management of stones. 75% of the renal calculi are composed of calcium oxalate or calcium phosphate. Your urinary findings for this one, hematuria is going to be the primary finding and crystals in the microscopic. Okay, the next section in this lecture, we're going to talk about metabolic disorders. So many abnormal urinalysis results related to metabolic disorders, also referred to as inborn errors of metabolism, and that's because many are caused by failure to inherit the gene to produce a particular enzyme that is needed for metabolism of a particular substance. So they're grouped into two categories. So they're either going to be of the overflow type or the renal type. With overflow, the normal metabolic pathway is disrupted, which causes increased plasma concentrations of unmetabolized substances, which overrides the reabsorptive capacity. So this is usually seen in carbohydrates, fats, and proteins. And then the renal type is due to tubular malfunctions. Many newborn screening tests are now available and utilized to test for these inborn errors of metabolism, because if these are not caught early, they can lead to death. So they're classified into amino acid disorders, porphyrin disorders, mucopolysaccharide disorders, purine and carbohydrate disorders. They can be further broken down within these groups as well, and we're not going to go into all of the subgroups, and we won't talk about every disease. So if this is something that interests you, you can look in the book and read about all of them. So within the group of amino acid disorders, we've got phenylketonuria, which is failure to inherit the gene to produce the enzyme phenylalanine hydroxylase. PKU is estimated to occur in 1 out of every 10 to 20,000 births and can lead to mental retardation if it's not detected. They say the urine has a mousy odor in patients with this disease. It can be treated early with dietary restrictions that can become less strict as the child ages and alternate metabolic pathways for phenylalanine are developed. The urine test for phenylpyruvic acid is a test that can be used. Positive in that test is a blue to green color. Okay, the next one is tyrosiluria. This condition is not very well understood. It could be caused by either inherited or metabolic defects. The urine can contain excess tyrosine or its degradation products. Most frequently seen is transitory tyrosinemia in premature infants because the liver is not developed enough to produce that needed enzyme yet. Melanuria occurs in the second metabolic pathway for tyrosine, responsible for production of melanin and other substances. Melanin is the pigment responsible for the color of hair, skin, and eyes, and if there is a lack of melanin produced, this results in albinism. Urine that darkens upon standing indicates the presence of melanin and could indicate proliferation of cancer-causing cells. Next is alkaptonuria, where the patient has a lack of the enzyme homogentisic acid oxidase, causing homogentisic acid to accumulate in the blood, tissues, and urine. Urine becomes darker after becoming alkaline from sitting at room temperature. It usually doesn't present in early life, but later it can cause brown pigments to deposit in body tissues, especially in the ears, and patients can develop liver and cardiac disorders. The ferric chloride test and clinitest can be used for screening. Next is maple syrup urine disease, which is a rare disorder caused by an inherited autosomal recessive trait. The amino acids involved are leucine, isoleucine, and valine, and the gene is lacking to break them down, so they accumulate in blood and urine. Newborns will begin to show signs at about 1 week, and the urine will have a very strong odor of maple syrup. Endocanuria, most of the tryptophan that enters the intestines is reabsorbed or converted to indole. There's several ways for increased amounts of tryptophan to be converted to indole, including a rare disorder called Hartnup disease, where you've got excess indole that ends up in the urine. It's colorless until it's oxidized and then will turn an indigo blue. So this one a lot of time is referred to as blue diaper syndrome. Cystinuria is not due to an error in metabolism, but a defect in the tubules to reabsorb cysteine filtered by the glomerulus. So cysteine crystals would be seen in the first morning urine. The cyanide nitroprusside screening test on urine can be used, and it would produce a red to purple color in urine that contains excess cysteine. Homocystinuria is a defect in the amino acid methionine that causes increase in homocysteine throughout the body. This one can result in failure to thrive, cataracts, mental retardation, thromboembolic problems, and death. Okay, the next group is the porphyrin disorders. Porphyrins are the intermediate compounds in the production of heme. Disorders associated with The porphyrin disorders are collectively known as the porphyrias, and they can be inherited or acquired. Conditions associated with the acquired form include lead poisoning, excessive alcohol intake, iron deficiency, chronic liver disease, and renal disease. The urine will be a port wine color after exposure to air, so it's just kind of a very dark burgundy color. The Hoesch and Watson-Schwartz are two different types of screening tests that can be used for this one. And the purine disorders, Lesch-Nyhan disease results in massive excretion of urinary uric acid crystals due to failure to inherit the gene that produces the enzyme that breaks down uric acid. The patient would have severe motor defects, mental retardation, a tendency towards self-destruction, gout, and renal calculi. And the first sign could be uric acid crystals in diapers that look like orange sand. And then the final group that we're going to mention are the carbohydrate disorders, where you'll see increased sugars in the urine, usually due to an inherited disorder. Infants and children should be screened for reducing substances using the clinitest. A positive clinitest and a negative reagent strip test for glucose is strongly suggestive of carbohydrate metabolism disorder. This can result in failure to thrive, liver disorders, cataracts, severe mental retardation. So that is the end of lecture 1, covering the renal disorders and metabolic inborn errors of metabolism.